Good morning. This is Patty Tuttle, Clinical Care Coordination Manager for TPMG. I'd like to help you learn this morning about working the Anthem Gap Report. The first thing you will need is to go to the OneAll Dropbox, and you'll see an Anthem folder. Open that, and you'll see a number of things here that we'll need. The key, GAPS 101, Anthem Revised, Gap Report Goals, and the 2019 Anthem Gap Definitions. Let's start there. Gap definitions, we'll first look at breast cancer screening. Mammograms are good for 24 months. Up until now, they were good for 27 months, but we see now that they come out on the GAP report as being due at 24 months. Cervical cancer screening, or PAP, is not difficult. Here are the rules. If just a PAP is done, it's good for 3 years. If a PAP and an HPV is done, it's good for 5 years. You want to look at the results, not the orders. Sometimes both will be ordered, but there aren't quite enough cells to do both, so just the PAP is done. Excuse me. So please read the results. A second reason you'll want to open the report and look at the results is sometimes it will say under categories that it is done, but when you open the actual report, you'll see the date is different, and it was the scan date that is listed under categories. So you want to make sure that you're reading the report to get the correct date, as well as what exactly we have results on. Well child visits are due annually, and they are through age 21. Of course, if you have someone 16 and over, I would probably term it as well visit rather than well child, as they might take offense to the term child. Diabetes, hemoglobin A1C testing, if a patient's diabetic, is due annually. Annual monitoring for persistent medications, which could be ACE and ARBs or could be diuretics. Either way, what we're looking for is 1 serum potassium and 1 serum creatinine annually. Asthma has changed slightly this year. Anthem is looking at patients between 5 and 64 who have persistent asthma, and they look at the ratio of controller meds to the total asthma medications. What they don't want to see is someone that's not taking their routine medications and only using a rescue inhaler in an emergency. They want to see that the ratio of refills is as it should be between controller meds and rescue medications. This is a 24-month look back. So in order to close this gap, simply discuss with the patient or the parent how they're supposed to be taking the asthma medication, and that Anthem has said somewhere in the last 24 months that they were not filling them as often as should be, and encourage them to do so. Chlamydia screening is for women aged 16 to 24, and it's recommended that they have one annually. This is a test for sexually active young women. You need to know that everyone in that age group is not simply put on the GAP report. These are young women who have indicated that they are sexually active by being on birth control pills for any reason, any other type of birth control that the insurance company is paying for, that they've had a pregnancy test in the past, that they've had an STD in the past, that they've had an abortion in the past. All these things are indicative of someone who is sexually active. Now, on occasion, we may get someone who is not sexually active. We had an incident last year of a young woman who had a sports injury, and prior to surgery, the doctor ran a pregnancy test. They are supposed to ask, but the family and the young lady was not aware this was done, and that is what actually put her on the report. But important to ask the patient if they're sexually active, or if they have ever been sexually active. They might say no because they are broken up with their boyfriend, but 3 months ago they were sexually active. So we'll need to have the chlamydia testing on women 16 to 24 that are sexually active and understand the reasons that they're put on the report, that it's not just everyone in that age group. Other things I'd like for you to know about the Anthem gaps is we are scored on the proportion of days our patients take their cholesterol medications. Anthem wants a minimum of 80% of the time, and this is based on medication claims that come into Anthem. If the dose is changed or the medication is discontinued, it's important to let the pharmacy know. Otherwise, it could look as if the patients are non-compliant with taking their medications. And this is triple weighted, so it is something we're going to put a lot of focus on this year. We're also scored on children who are diagnosed with pharyngitis and receive an antibiotic. If a child comes in with a sore throat and a strep test is done, but let's say they were originally, when they came in, diagnosed with pharyngitis, and then the strep test was done, and nobody goes back to change the diagnosis, it's going to look like we gave an antibiotic for pharyngitis rather than strep throat. So it's important the diagnosis has to be changed to reflect this, or it's held against us. Back pain. We're scored on how many of our patients are diagnosed with low back pain and do not receive imaging within the first 28 days. Anthem feels that low back pain has been a cause of overutilizing imaging, and their preference is that folks with low back pain not have imaging tests within 28 days originally of the diagnosis. Childhood immunizations. Anthem wants each child to have one MMR and one chickenpox by age 2, and we are scored on that. From birth to 15 months, they want at least 6 well baby visits in that time frame. We are always looking at ER use for non-emergency conditions as well as hospital admissions for chronic conditions. We would like for both of those scores to be as low as possible, of course. And now I think it's time to give a little bit of a brief overview of why we do gaps. Gaps are simply HEDIS measures or tests that the insurance companies want our patients to have periodically to keep them in the best health possible. In addition to that, TPMG is in several shared savings programs, and this is where another way that the gaps fit in. With shared savings programs, the insurance company looks at the entire panel of patients, and we have approximately 26,000 Anthem patients. So they look at all of those patients, and they take an average HCC score. And many of you know what that is, but for those of you who haven't heard the term, let's say I had diabetes as a diagnosis, CHF, COPD, and I'm a bilateral amputee. And you had just diabetes. My HCC score would be higher than yours, and they would expect it to cost more money to take care of me for a year than it would to take care of you for a year. So they look at our whole panel of patients, and they come up with an average HCC score. And with that, they say to us, You should be able to take care of this whole group of patients for an entire year for X amount of dollars. To qualify for any shared savings, the first thing we have to do is to come under that amount of money. In care coordination, we have several nurses that call patients when they have been discharged from the hospital. They review their discharge directions, they review their medications, they make sure they have a follow-up scheduled with the PCP or possibly specialist or surgeon, depending on what they were in the hospital for. We have another group of young ladies that call folks that have been to the ER for non-emergency reasons. They tell those folks where they could have gone, might be our after-hours clinic. If they are not near that, it might have been an urgent care center in their area, and they tell them what hours it's open, as well as how much money they could save by getting the right care at the right time at the right location. Other things that we all do is encourage generic medications or possibly brand formulary. That's another way of cost cutting. We try to have our patients' tests scheduled at high quality, low to moderate cost facilities. For instance, if a patient needed an MRI, we could do it at TPMG imaging, or they could have it done at the hospital. They have it done at the hospital, it more than likely is going to be approximately 3 times as much as TPMG, which their copay will then be 3 times as much. CHKD charges 5 times as much for most of their MRIs. So we try to recommend that they go to a high quality, moderate to low cost facility to have their testing done. And this helps save money as well. And all of those things help get us under the financial threshold, which is part 1 of qualifying for shared savings. The second part is how much money, once we pass that threshold, how much money we can earn from shared savings. How much money we can earn from shared savings depends on how we do on our gap report, what our scores are in each area. And that's where this becomes very important. We've done pretty well for the last few years, and so this year Anthem is in a risk year. Well, we are in a risk year with Anthem. And what that means is, if we do well, it increases the amount of money we can earn in the shared savings program. If we don't do well, we can end up owing Anthem money, and it would be a considerable amount of money. So it's very important that everyone work these gaps throughout the year and do their very best to get the gaps closed. So next, let's take a look at the key. And what the key is are the answers that will go on the gap report as you're working it. Okay, there's going to be an answer column on the gap report where you'll put one of the answers below, as well as the date and your initials. So let's say someone was due a mammogram and you either called the patient and let the patient know that, or they were in the office and you let them know that. You would put C, the date you spoke with the patient, and your initials. On rare occasions, we use CB90. And that is for situations, it means call back in 90 days. Generally, we try to reach out on open gaps at least monthly. But a CB90 would be, let's say you called the patient to tell her she was due for a test, and she said, I've just had a knee replacement. I just can't go right now. I just got out of the hospital. That would be a CB90. A death to the immediate family, that would be a CB90. CB90 could be used for students who are away at college. However, be very careful with that, because if a school break comes up, please get the gap scheduled for closure during the school break, and there are several throughout the year. So don't rely on CB90 indefinitely. We want to go on and at least get it scheduled. The patients come in. Care coordination will send a letter out for certain gaps. We'll review which ones shortly. And we will send one letter. Towards the end of the Anthem year, we do not send letters because we're getting down to the very end of the year and we need to verbally discuss with patients their open gaps and get them scheduled. But April 1st is the first day of the Anthem measurement period, and it ends March 31st. So today's April 2nd. We're a brand new year as of yesterday in the Anthem world. All of the other companies, it goes from January 1st to December 31st. So if you need a letter sent and there has not been one sent before, we'll put an L and make the box yellow. S is for scheduled appointment. This means when you spoke with the patient, you scheduled the appointment for the gap closure yourself. So you would put S, the date, and your initials. When you're working the report, if you see there's already an appointment existing, you would put A, the date of the appointment, and your initials. So let's say the patient needs a mammogram, and you see they've already got an appointment at imaging for a mammogram. You would put A, the date of the appointment, and your initials. I don't think we need to use R, referral done with this insurance program. I've not seen that necessary. D is our favorite letter. It means the gap is done, it's closed. You put a D, the date it was done, and your initials. Now, with all of these reports, they are claims-based. So what that means is until Anthem gets a claim in for something and pays it, it's going to continue to show up on the gap report. They say this runs about 90 days behind. I have seen it run even longer. So anticipate that you're going to see some that are done. You might do it 1 month and put a done date, and it might be on the next month's report. Just simply put the same done date in your initials and move on to the next gap. T means transferred care outside of TPMG. You don't need to tell me the reason. Just put T, the date they transferred out, and your initials. Of course, if the gap was closed before they transferred out, please go with the D for done, the date it was done, and your initials. RF stands for refused. Please use that sparingly. A good example for a refusal might be a patient with severe dementia, and she's not going to have a mammogram because we know that she's not going to stand there and have that done. She's not going to understand it. So that would be refusal. Refusal is, I'm not going to get this done. It's not to be used, for instance, if the patient says, I know I need to have that done, but I don't have the money right now. That's not a refusal. So please use refusal sparingly. N is for patients that are living in a nursing home. If they're just there for a skilled nursing stay or rehab after a surgery, you can certainly note that, but if a patient is living there, that's the one I'm interested in, because the next question I'm going to ask you is your physician visiting them and continuing to take care of them, and if they're not, I'm going to try to have the patient removed from the gap report. WD stands for wrong doctor. And I mean the correct doctor is within TPMG. What I'd like for you to do is put WD for wrong doctor, put the correct TPMG physician's name, and then date it. That's something I can manually go in and change from month to month. It's a lengthy process, but I do try very hard to get the right patients on the right gap report so that the gap can get closed. If it is on the gap report for another doctor in your office, please give it to the person that's working those gaps, or just go on and work it. Do not put WD and waste an entire month when the person still comes to your office. Just go on and have that gap worked, please. If your office manager is refusing to allow appointments until the situation is cleared up, please put OM. How I handle that is, if a gap can be closed outside of TPMG, then I may send the patient a letter from TPMG administration letting them know that they're late for that gap and they need to get it closed. Say, for instance, it's a pap smear, but the patient usually goes to someone outside of TPMG. I may go on and send a letter letting them know that they're due or past due, and just put TPMG administration on the letter in hopes that they will go get the test done and the gap will close, because we're held accountable for the gap, period. In the insurance company's eyes, the PCP is accountable for all gaps, end of story. It doesn't matter if they go to endocrinology, it doesn't matter if they go to OBGYN, the PCP is held accountable. LS means letter sent, and if we send a letter, say in March, it's okay for the very next month to put LS, letter sent, but that's not something we want to carry over for months. In other words, at the end of the year, which is March 31st, I don't want to see that the patient. Let me restate that. If a letter is sent early in the year, the new Anthem year starts in April. So let's say we sent a letter out in April. In May, if you wanted to use LS, letter sent, and put the date it was sent, which was the prior month, that's fine. But I don't want to see, when the year comes to an end, March 31st, I don't like to see, we sent a letter back in June, or we sent a letter in March. We want you to reach out monthly and try to get the gaps closed. So only put that at the beginning of the Anthem year if you choose to, but only for a month. And then after that, reach out and make contact with the patient again. These are the codes I would like highlighted in red, please. If a patient is dismissed or terminated and was sent a dismissal letter from TPMG and there's a copy in a chart, then put X and highlight the box in red. This is really important because if a patient is terminated from TPMG, I have to send a letter to Anthem, the termination letter to Anthem, and at that point they will remove all that patient's medical costs for the year from TPMG. Now, when we're trying to get under a financial threshold, it's important that we not be carrying around expenses of patients that we are no longer treating. So please let me know as soon as any Anthem patients are terminated. W is for wrong diagnosis, and this most often is going to come up for diabetes. And sometimes it comes up for diabetes because someone along the way might have been TPMG, might have been a hospital, might have been another physician, has diagnosed the patient with diabetes, and they're not diabetic, and often that happened in the past to try to have labs covered. If I look at the chart and the patient's not diagnosed with diabetes and they're not taking an oral diabetic medication or insulin, I'll manually remove that from the report. But if I look at the chart and the patient is taking an oral diabetic medication or insulin, that's what's flagging the diagnosis of diabetes. And there's really not anything I can do about that if that's the case. N stands for not seen in greater than 30 months. This means the patient has not seen the PCP in 30 months or more. If the patient goes to after hours care, that counts. If we're still refilling their medication, it counts. We're still treating them as a patient. But if we, as TPMG, if we have not seen the patient or treated the patient or prescribed for the patient in greater than 30 months, and they're still on the gap report, I can have the patient removed. E is for expired, and if you have the date the patient passed away, please put the date of death in your initials. NS stands for never seen. That means never seen at TPMG. Most often, if you can't find a patient, I'm going to go in the Anthem system and find that they're under a different name. Sometimes children are adopted or women get married. But every once in a while, we will get a patient on a gap report that we've just plain never seen. And it's important for me to know that because I want them and their expenses removed from TPMG. NSPCP stands for never seen by a TPMG PCP, only a specialist. So if you happen to have someone on your report that you've never seen, but they have seen a specialist, you can certainly let me know that and I'll look into it. Next, if you go back into the drop box under Anthem, I'd like for you to have by your side as you're working the gaps 101 Anthem, latest revision was 2/15/19. Okay. I always advise that people have the previous month's gaps next to them when they're working the new gap report. It's going to save you time knowing what was done the month prior. For Anthem gaps, we send letters for well child, mammogram, and PAP. The diabetic eye exam is no longer a gap this year. We, in the past, did send letters for that. But well child, mammogram, and PAP we send letters for. The lab work, you will need to call the patient and make arrangements for them to have that done. We only send one letter. If a letter's already been sent, it's time for another action. Please try to reach the patient by phone and get that scheduled. Have the definitions close at hand. Again, they can be found in the One All folder, Anthem Gap Reports, Definitions. So step one, when you're first starting to work the gaps, first look under alerts. And the reason is, if there's been a letter sent in the past, that's where we're going to note that. So you may see, for instance, Mammo LS for Mammo letter sent, the date we sent it, and the initials of the person in care coordination who sent the letter. So we want to look there first. Next, we want to look under appointments to see if there's already an appointment scheduled to close the gap. For instance, the mammogram would be an example. If we were looking under appointments and we saw the patient had an appointment at imaging for a mammogram, we would put put A for appointment on the gap report, the date it's scheduled, and your initials. Step 3, we also look on the EPM side, and the reason is if a patient's been terminated, we don't want to say, hey, come in the office for this test after we've told them we're not going to see them as a patient anymore. So we really look under alerts for that, as well as on the EPM site to see if by any chance the patient was terminated. Knock on wood, that will never happen, that we accidentally send a letter to someone that's been terminated, but as long as it's marked in one of those two places as it should be, that'll never happen. Next, look at the PCP. If it says no PCP, or you do not recognize the name and you don't see a termination letter, then you may need to go to the OM or call me and let me help you figure out what the situation is there and who that patient is seeing for a PCP. Step 5, if the patient's not in the EMR, and please look patient up by date of birth and then name, again, because people will get married, change their names, hyphenate their names in our system, not hyphenated in Anthem, be under Deborah Jones in our system, be under Debbie Jones in Anthem. There's all kinds of situations where it can be the same patient, so carefully look. And if the patient's not been seen, then certainly put NS, and I will follow up and look in the Anthem system as well. Here are some notes that Tiffany, the regional ops manager, put together about gap report goals. Of course, is to close as many gaps as possible, not just work the gap report, but close the gaps. The Anthem year again runs from April 1st to March 31st annually. The other insurance companies are based on the calendar year. Personally, I like to have this not due at the same time. To me, is helpful because it kind of spreads out when some things are due, so that it's not really difficult to get everything, all the T's crossed and the I's dotted at the very last month of the year, which is a busy month. So I personally like it being due by March 31st. Documentation. Reviewing the gaps prior to working the report. Patient names can appear more than once, depending on if the patient has more than one gap open. So look carefully before you pick up the phone and call the patient, because you do want to talk about all the gaps in one phone call. Review the previous notes to assess the next steps needed in filling the gaps. There comes a point where if the patient ignores your calls and hasn't been coming in, especially if they are frequenting the ER, we might have to consider termination. So please list the number of calls or the dates of each call so that we can get a good picture of what's going on there. Make sure you're using your huddle reports. That's the best advice I can give you at TPMG. The reports are there. They tell you what gaps are due. And if you look at the huddle report, as patients are coming in, you are really closing gaps or have the opportunity to close gaps before they show up on a report. This is key to your success with gap reports, to use the huddle summary. If you've sent a patient or you know a patient's having something done outside of KPMG, please send for the report. It's not done until the report's in the chart, so it has to be there, and we just want to make sure you're staying on top of getting the results. Be clear and precise in documentation if the gap remains open. This is especially important during the last quarter of the gap year. That's very true because we want to see that you're trying in earnest to get the gaps closed. I'm not going to read each word of this, but I'd like for you to read it because all of these are important things and they're tips that Tiffany has picked up throughout the last few years of Anthem gap reports. Set up follow-up dates if you're awaiting results, patient callbacks or appointment dates so you know they came in. This way, if the patient calls back, someone can schedule the patient or get the information you're seeking if you're unavailable. If a patient decides to schedule on their own, find out where they plan to schedule so you can follow up with the specialist for appointment information and results. All these things are very important. Please do not use, we'll discuss at next office visit, no office visit scheduled, or not due for office visit yet. This is not an effort to close a gap, and we need you to reach out to the patients and try to close a gap. It's one thing if their name newly appears on the gap report and they're due in Tuesday, that's one thing. But just to blatantly say they don't have an appointment scheduled and not deal with it is not working the gap report, nor is it attempting to close gaps. Again, please read this in its entirety. It will help you tremendously. For some reason, the biggest difficulty that I'm seeing among sites is they're not opening the PAP reports and reading them to see if a PAP or an HPV was done, to see if they're both done. The best advice I can give you on this one, of course, is to read the report and see what was done. And also, I would put after the done date 3 years or 5 years so you know what it's good for and you're not constantly looking it up. If the patient has had a hysterectomy or a mastectomy, this needs to be coded by the physician during an office visit on a bill that goes to the insurance company. They only know what we send them, and the way they treat any surgical removal of a body part is it grows back if you don't continue to code it at least annually. So if you see hysterectomies or mastectomies coming up on your gap report, what seems to be working best is to, and of course I want you to discuss it with your office manager, but what seems to be working best is to note this under alert so when the patient comes in, the physician can be encouraged to use the correct diagnosis to remove it from the gap report as the patient's there. But again, that's a decision for your physicians and office managers to make. But if they're in agreement, that should help you quite a bit. This concludes the Anthem gap report training. Again, if you have any questions, please call me at 788-3072. Thank you.